Hello and welcome to our first webinar of Aortic Dissection Awareness Week 2021, hosted by the John Ritter Foundation for Aortic Health. We are so pleased that you're joining us today for this very special webinar by the esteemed Dr. Dianna Milewicz, but I wanted to do a little bit of housekeeping before we got started. I'm Meredith Ford O'Neill. I am the new CEO of the John Ritter Foundation and so honored to be here with you. I'm also an aortic dissection survivor myself. When I was 37 and a half weeks pregnant, I had an ascending aortic dissection. So I had a C-section and a C-section and open heart surgery on the same table. So we're a community. And so I'm so glad that we're all coming together today to hear this extremely important information. I hope you join us for our other webinars, including a fireside chat with Amy and the Ritter family this evening. Tomorrow, we're going to be hearing from some of our partners in the medical field. And then the next day, we're going to hear from Dr. Siddharth Prakash about all the exercise questions that we get from you guys on a regular basis. And then today on social media, you're going to see a lot of purple pinkies, just like mine. And we want you to paint your purple pinky fingernail and make a purple pinky promise to talk to your doctor about your aortic health. And then challenge 3 of your friends and tag them to join you, because together we can make a difference. Without further ado, you don't want to hear from me anymore. Let me introduce the woman of the hour, Dr. Dianna Milewicz. Dr. Milewicz?
Hi, thank you, Meredith, and welcome everybody. I'm going to be speaking to you today about the work by the John Ritter Research Program, why it got founded and what we're doing and what we've done in the past, what we hope to do in the future. I'm joined by some of the people that are part of the John Ritter Research Program and certainly a big part of the success of the program. And I want them to go ahead and introduce themselves. Elena, why don't you go ahead and start?
Sure. Hi, everyone. My name is Elena Checki. I am very happy that you're all joining for this webinar and discussion. I am a genetic counselor at the University of Texas in Houston, and I work with Dr. Milewicz and with the John Ritter Research Program. I see patients with Dr. Milewicz in Houston in the clinic, and I am involved in a study that Dr. Milewicz will discuss a little bit that involves identifying the risk factors and genetic underpinning for sporadic aortic dissection. So we'll be chatting about that in a bit, but very nice to meet all of you.
And Ellen, do you want to go ahead and introduce yourself?
Sure. Hi, everyone. Welcome. My name is Ellen Hostetler, and I work on a project known as the Montalcino Aortic Consortium, or MAC for short, because that can be quite a mouthful. And our MAC project focuses on patients who have a known genetic diagnosis, such as Loeys-Dietz syndrome, ACTA2 mutations, PRKG1, et cetera. So these are folks who know that they're at risk for genetic aortic disease. And we're currently recruiting those folks and following them clinically to learn more about these conditions and how we can help them in the future with better recommendations and prevent disease. So I work with those patients all over the world and contact them and their families as they're diagnosed with these disorders.
Thank you, Ellen. And that, last but not least, is Bella.
Isabella. Hi, everyone. Welcome. Yeah, my name is Isabella Marin, or otherwise known as Bella. I'm a research nurse who works with Ellen and Elena and Dr. Milewicz, and I'm primarily involved in the inherited familial aortopathy study. So this study, we are working on finding new genes that can contribute to aortic disease. So I help recruit families, consent them, and follow up with our families and participants enrolled to make sure that their research charts are up to date, so we can continue to work on analysis and identifying the genes of these unfound families. So I do a lot of communication with participants, and I also help navigate patients to local genetics resources and kind of help provide a direction when somebody's diagnosed with an aneurysm or a dissection and they reach out to us.
Great. I know many of you have talked to one or more of the individuals at the John Ritter Research Program, so this gives you a chance to put a face to the name of the person you've talked to. So, and they, like I said, are the real reason for the success of the John Ritter Research Program. So, I'm going to start just by talking about the disease that we are focused on and why we are focused on this disease. So here's a picture of just a normal aorta. The heart sits right here and pumps blood up into the aorta. And an aneurysm is an enlargement or dilation of the aorta when it starts getting larger, as shown in this picture here. And when it reaches size and it becomes unstable, and that can lead to an aortic dissection. The aneurysms tend to be totally asymptomatic. People don't know they have it unless they get imaging. But an aortic dissection is typically associated with the acute onset of chest pain and a feeling things are not right, or there's something tearing in the chest or in the back. And this is where the blood goes from where it should be inside the aorta into the wall and starts tearing the wall apart. And that is associated with many complications and can cause sudden death. But if we go in and aneurysm before the dissection, we can prevent the complications and premature deaths due to the dissection. So this is why I actually work on this disease. It's because we have treatment to prevent the aortic dissections if we know somebody is at risk. And I want to mention just briefly that what we had, that the sort of predisposition and the aneurysm formation was talking about type A dissections that occur right where the aneurysms occur. That's where the tear in the aorta occurs. And for some reason, there's a type of dissection called type B, or descending aortic dissections, that start right after the arteries that go up to the brain and the arteries to the arms go off the aorta. The tear is right at the beginning where the aorta goes down, right close to the spine. And in this case, the dissection always goes down. And this kind of dissection is less deadly than type A dissections, but can lead to complications. And for some reason, this is part of the spectrum. There's typically no enlargement before this type of dissection occurs, so we don't have a really good way of predicting these dissections. But like I said, they're not deadly, or tend not to be deadly like the type A dissections are, but they can lead to complications. So we want to make sure we don't miss that type of dissection. Once again, this type B dissections or descending dissections are associated with the same pain and feeling that there's a tear or something's wrong in the chest, but because it goes down the aorta, it can also be in the abdomen. And this is just going over how we manage the aneurysms. We image them every year. We treat them with medications to prevent the progressive enlargement. We tell people to alter their exercise and what they do, and really stop doing any type of exercise that is isometric. Dr. Prakash will talk about this later in the week. So if you want more details in terms of what we recommend and don't recommend in terms of activity, please talk. But the mainstay of treatment of those aneurysms that lead to the dissection is that surgical repair. And we typically in the past have recommend when the aorta reaches about 5 centimeters enlarged, or 5.5, to go to surgery. But we're starting to pull down that number and to 4, even 4.5, because we know in some people that have genetically triggered aortic disease, that the dissections start before the aorta reaches 5 centimeters. So now we've gone down to recommendations at 5 centimeters, and I'll talk about a situation where we even recommended repair of a completely normal aorta. So my approach to this disease was to try to identify who in the population was at risk for this disease by identifying genetic changes or changes in our DNA that predispose people to this disease. And if you look at the spectrum of aortic disease, on one side, at the very earliest onset disease, is you have people that have syndromes, and they have not only the aortic disease, but they have features, outward features that allow you to identify these individuals in the general population. And that's people that, like this individual here, had Marfan syndrome. So he has a mutation in a gene called FBN1 that's conferring a high risk for aortic aneurysms and dissections, but he also have these long fingers and other skeletal abnormalities and eye problems that allow us to pick them out from the general population. And that, but we also, and this tends to be inherited in an autosomal dominant manner. And in families, that means it can be passed from one generation to the next. And somebody with the disease has a 50-50 chance of passing it on to their children. But we also know that there's families that have an alteration in a gene that confers the same high risk for thoracic disease, but they don't have these syndromic features, and they're much harder to pick out of the general population. And John Ritter was an example of that. And in these families, they have one change in the gene, in the human genome, in one gene that confers the high risk, and it ends up being passed from one generation, similar to Marfan syndrome. And then there's a pretty clear delineation that when you go to the older onset disease, like occurred in Richard Kirk and even in Michael DeBakey, a very famous vascular surgeon who pioneered the repair of aorta, that they most likely had some genetic changes in their genes that predisposed these, but they didn't have a variant that absolutely was confirmed they would get the disease. So they have what we call a low risk variant, and in combination with the environment they're in or particular features they have, like a bicuspid aortic valve or polarly controlled hypertension, they are the ones that end up with the disease. So we really, to begin with, went after these high risk genes that cause disease. And more recently, we're planning to go after these low risk variants that, in combination with environmental factors, disease. So I want to just mention that John Ritter did not know he had a family history of disease before his dissection. After his dissection and unfortunate passing from an aortic dissection, we imaged the family members and found out that his brother had disease. So it was John and his brother that were both affected. So once again, that takes it from a low risk gene. You've got multiple family members affected. Tex Ritter, who was one of the famous cowboys back in the 1920s and 30s, that he also died of a dissection. He died suddenly and clutched his chest and fell over and passed. And so most likely that was due to an aortic dissection. So we had determined back in the late 1990s that in people that had thoracic aortic aneurysms or dissection, that 1 out of 5 had the history of disease, even without those syndromic features like people in Marfan, like Marfan patients. And in almost all the families, this is inherited in that autosomal dominant family history and draw it as a pedigree. And just to go through this quickly, Men are squares and women are circles. Designating men as squares is no surprise to us women. And said line between two people mean they're married, and then the line down indicates their children. So in this case, this individual had 4 children, and 2 of them had aortic disease. And this woman did not have aortic disease, but had passed on the gene to 2 of their children who went on to have aortic disease. So this is where the gene's being passed from one generation to the next. And in some cases, when it passes through somebody like this woman, they can get the mutant gene, pass it on to their children, but have no evidence of disease themselves. And this is called decreased. And so it makes it sometimes hard to realize there's a family predisposition when you have decreased penetrance like this in a family. And so, we had been working on identifying the genes and recruiting families like this to begin to define the genes that cause disease, like families like John Ritter's family. And we had been recruiting families, and one of the families was Tyler Cayley's family. And Tyler's family is probably the reason why we got started the John Ritter Research Program. So I want to take a minute to tell his story. Here's his family of aortic dissections. He's right here. And his father had survived a dissection. His uncle had died of a dissection, plus he had cousins with dissections. And he had found his defective gene study really early, back in the early 2000s. And we had actually identified that he had inherited the risk, the high risk gene for thoracic aortic disease. And we told him that he had this risk, but he was in college. He thought he would just wait until the summertime when he wasn't so busy to get imaging of his aorta. We had strongly recommend that he image his aorta. And he had, and one night he was studying when he had the sudden onset of chest pain. He knew about dissections because of his family history, and he knew it was at risk for a dissection because we had told him he inherited the altered gene. And he went emergency rooms, and they sent him home saying you don't have Marfan syndrome and that there is no genetic risk in families beyond Marfan syndrome. And this is despite the fact that for 5 years we had been publishing papers, our group and other, describing the risk in families that did not have Marfan syndrome. So the physicians were not keeping up with the literature. And I got lucky, and unfortunately, after the visit to the 3rd emergency, Tyler Cayley died of an acute aortic dissection, and the pedigree that's indicated by the slash through his symbol. So this really made it obvious to me that we could be doing this research and finding these genes, but unless we got the information out to physicians, that it wasn't going to really change the outcome in ways. And so I actually was lucky to be contacted by one of the editors of the journal, and I convinced him to write a story in the Wall Street Journal about how families with aortic dissection were being mismanaged. And these families, because they didn't have the syndromic features of Marfan syndrome. And up on the front page of the Wall Street Journal, here's Tyler down here. And this was very useful for the individual Kevin Helliker that I convinced to write this article. He went on to write a few other articles on aortic disease and ended up winning a Pulitzer Prize for his work. But Amy read this paper and contacted me about the risk to the Ritter family members. We got them imaged and figured that out. But then I approached her about starting the John Ritter Research Program, where we could provide genetic counseling to people that contacted the John Ritter Foundation and provide the correct information of who's at risk for a dissection when it's running in the family, how to get genetic testing locally, and how to get genetic counseling locally. And if they couldn't get it, we would go ahead and provide that counseling. And at the same time, we recruit these individuals into our research program. So this ended up being a partnership where the John Ritter Research Program was based in Houston, and worked carefully with the John Ritter Foundation, which is based in LA. So recruited over 1,000 families into our studies that have 2 or more members with thoracic aortic disease. This means a large number of participants in our study. And we've used this to find a large number of genes that cause aortic disease. And everything in red here's a list of genes that cause thoracic aortic disease, aneurysms, and dissections to be inherited in families. And the ones highlighted in red, like I said, were those that have been found by my laboratory, and the ones in black have been found by other laboratories. And so we're really, despite finding all these genes, we can only explain the disease in about 30% of families. And our estimates are that we still have another approximately 60 to 100 genes to find. So we're still working on identifying all those genes. Early on, we realized there was a lot of genetic heterogeneity in these families in terms of the age of onset of the disease, how large the aneurysm was before they dissected, and what was the other associated vascular diseases. And this is a family from Texas where the family came in, this individual dissection, and had a huge aneurysm, about 8 centimeters. And he had an uncle, he had a big ascending aorta. And when we brought this family in for imaging, we found a large number of people with very large aneurysms, and we sent them to surgery to repair the aneurysm. But it appears with this family, this risk of death, even when the aorta gets very big, is very low, because all these individuals in this family with aneurysm, there's only one that's, and the exact opposite is true of this family. In this family, anybody who died of dissection has had no enlargement of their aorta prior to the dissection. So until we find this gene, there's no marker we have as to who's at risk on a type A dissection. So there's a wide degree of variability when we get to onset, like I said, and other vascular diseases. So that's when the Montalcino Aortic Consortium, I founded this in 2013 and pulled aortic centers from around in the US, Canada, throughout Europe, Australia, and New Zealand, where there is genetic testing for the genes that I just showed you, so that we can find those people in the population and use their clinical data to define the age of onset of aortic disease and all these other risks. So I was amazed when I started this, and because there were many aortic centers that signed on early on to be part of this consortium. And these are physicians that are donating their time to enter their data on their patients. It's just such a rewarding feeling to know physicians and aortic centers around the world are willing to take the time and effort to put their data in and receive nothing in return other than data on how to manage their patients. So we've been publishing all the different risks associated with each gene, have had a large number of publications, and I just want to show you the current data coming out
Dr.
of that
Milewicz?
just in 1 or 2 slides. Yeah.
Dr. Milewicz. So I just wanted to mention to everyone that we have the chat open for questions. And before you move on to talking about some of the genes, there was one really good question, I think, that related to the pedigrees, the family histories you were showing, because you mentioned autosomal dominant inheritance, but there are more males that appear to be affected than females. And I thought perhaps you could comment on why that is, or why we see that.
So we don't know why that is, but that is a consistent feature of the disease, that in the general population, it's about 2/3 men and 1/3 women. In our families, when we see that decreased penetrance where somebody gets the gene and passes it on to their children, but doesn't have the disease themselves, that tends to be in women. We do not know why this occurs. And with some dramatic, and for TGF, the men in the family present much younger than the women with aortic disease, and the women are less penetrant, less likely to have aortic disease in their lifetime. And that is a really important question as to why it's more prevalent and more penetrant in men. And once again, there's so many different arms we can go in the research. We just haven't gotten to that question yet. Very good question, though.
Yep. And by penetrance, you mean someone who inherits the gene change, but doesn't have a dissection or doesn't develop an aneurysm.
Correct.
Okay.
Exactly. Yeah. And I just want to show you a couple of slides on the data. This is the data on the first 1,069 cases that we had in the Montalcino aorta, based on mutations in 7 genes. And this is the average age of an event. And we define that as going to surgery to repair an aneurysm or presenting with either a type A or a type B dissection. So overall, if you look at all the genes, all 7 genes, the average age of onset of the 50% point, where somebody has an aortic event, this is the age of onset of those events. This is reflects the number of people that have had an event. So 50% of the people with mutations in these 7 genes have had an event by the age of 50 overall. But when we on into the individual genes, so here's those genes ACTA2, MYLK, and PRKG1. And these are those Loeys-Dietz syndrome genes, TGFBR1, TGFBR2, E2, and SMAD3. But you can see there's a wide range of onset when we start looking at the individual genes. So here at 50% of the people with PRKG1 mutations have had an event in the late 30s or mid 30s. Whereas if you look at myosin light chain kinase, only at the age of 70, only 50% of the people have had an aortic event. And the same is true of those genes we group together as the Loeys-Dietz syndrome genes or LDS genes. Here's TGFBR2, where 50% have had an event by age 40. But SMAD3, it's well into their late 50s before 50% have had an event. So the gene does dictate what age people will have an event, and will also tell you whether we have to worry about children having an event. If we look at those LDS genes, the only genes that are associated with childhood onset disease are TGFBR1 and 2, whereas TGFB2 and SMAD3 are not associated with events until people are in their early. And over here, there doesn't seem to be much in the way of events in children. And then in ACTA2 in their teenage years, we start to see events, and then a little bit later for each gene. So this graph alone has a lot of information in terms of how to manage the people, both in terms of being successful in preventing dissections, but also in terms of how frequently we have to image the aorta. Unlike for SMAD3, this data says, yes, we probably have to check children with SMAD3 mutations, but we perhaps can move to imaging every 2 to 3 years in childhood and not annual imaging. And so that provides us a lot. The Montalcino Aortic Consortium provides a lot of data, and we're in the process of publishing it, but we really plan to set up treatment guidelines based on the data coming out of the Montalcino Aortic Consortium so we can get this to physicians around the world. And I just want to talk about this one story. This was a family with a PRKG1 mutation. This is the gene that leads to the earliest onset of aortic events. And in these families, we actually see aortic dissections occurring before aneurysm here. So this is once again the age of onset of the disease and how many people have had that complication. And the pink is for dissection and the blue is for aneurysms. And we don't understand why this particular gene causes dissections so young. And the people that have these dissections, about 2/3 are type A, 1/3 are type B. But in those 2/3 that are type A, they tend not to have enlargement of the aorta. And in this particular case, had the PRKG1 mutation and had a completely normal aorta, but had lost 2 older brothers to type A, one of which was just 18 years old. So the family elected to go ahead and repair her aorta despite having no enlargement of the aorta. And she was repaired at the age of 17 because her brother died of the dissection at the age of 18. So this really illustrates why we need to know the gene and how that gene presents and exactly to tell us how to properly manage these families. So the last thing I want to talk about is that we have been working on those low risk genetic variants that we find a little bit older onset of disease. And this represents 80% of the people that have dissections. So we really have to start working on what are the genetic variants and what are those environmental risk factors. And we want to be able to put them together and really identify who in the general population is at risk for aortic disease. So we know some of the genetic variants, but we still don't know the majority of genetic variants that lead to this predisposition. And once again, we know some of those risk factors. It's hypertension, what you do in terms of activity and heavy. There's people that dissect just with normal aortas when they go to lift really heavy weights. We know pregnancy is another risk factor, and Meredith mentioned that she had her dissection was towards the end of her pregnancy. And then more recently, we've started to identify drugs that are commonly used, like a type of antibiotic called fluoroquinolones that increase the risk for dissections. And I can tell you as a physician working in the field, this fluoroquinolone story was a surprise and really makes me wonder if there's other drugs or common things that we use that might be increasing the risk of dissection in individuals. So we want to use an approach used for other disease. They actually use this approach for abdominal aortic aneurysms. And in this case, we want to get that genetic data, but we also want to get all the health records about what the images, what drugs they were on when they came in with their dissection, but also add in data from studies of human tissue in terms of what goes on in the tissue and data from different mouse models of the disease to put it all together and use machine learning and artificial intelligence to come up with a risk score dissection that will include the genetics, but also include high risk activity and information in terms of drugs that increase the risk for dissection. So that is the plan going forward. We hope to launch, we've already launched phase and hope for launch the bigger phase of the study and get many more people recruited in this program within the next 6 months. So just in conclusion, if someone in your family has had an aneurysm or a dissection, please get genetic counseling. I want to thank everyone who's already participated in our research, but please consider participating if you haven't done so. And together, I think we can move to a goal of the John Ritter Foundation of preventing acute aortic dissections in everyone in the population. And the last thing I want to mention, the John Ritter Research Program gets funding from the John Ritter Foundation, and that funding allows us to provide genetic counseling to anyone who for the JRRP. And then once again, we will offer the chance to participate in our research study, but you can still contact us even if you don't decide, and we'll provide the information even if you don't decide to participate in the research. We receive funding from the National Institute of Health, and particularly the Heart, Lung, and Blood Institute, from the American Heart Association, and from the Genetic Aortic Disorder Association of Canada. They have provided of funding for MAC, and we're very grateful for that, and also from the Marfan Foundation. And then from individual foundations, primarily started due to losing somebody in their family with an aortic dissection. And we're just really grateful to all the funding. And here is the list of everybody that participates in these studies in my group. Right now, there's been a lot of people in the past that are not listed here, but as you can see, Elena, Bella, and Ellen are at the top of the list. Dr. been working with me for many, many years, trying to find all these genes, and has been a major asset to our program. So I want to now open it up for questions. And stop sharing my screen. I can share the screen if I need to in the future.
I think there have been a lot of great questions that have come in, and you provided a fantastic overview. One of the questions, a couple of them kind of relate to family history, genetic testing, and monitoring, and screening in different scenarios. So when you were talking about the need for genetic counseling and genetic testing, two things that come up, and they are after you undergo genetic testing. Some people get negative results where no genetic cause has been identified. Other people get these findings that are uncertain, these variants of uncertain significance. And so what do we recommend for patients with these uncertain genetic findings or negative results? And how do you go about imaging and screening family members who are at risk?
So great questions. And Elena, do you want to take a stab of answering this?
Well, okay. So for genetic testing, these variants of uncertain significance are pretty common. And Dr. Milewicz can reflect on this, but over the years, as we've identified more genes, these genetic testing panels have grown. And so when you're screening and sequencing more genes, there's a higher likelihood of finding variants in the genes. And we aren't always sure if they're associated with an increased risk for aortic disease or not. And so generally, the recommendation is that when a variant of uncertain uncertain significance, or VUS, as we call them, is identified, we really treat them as negative test results, meaning the recommendations Dr. Milewicz mentioned with regard to aortic repair at earlier sizes, or other recommendations that you would make based on the gene don't apply to VUS findings. There are some exceptions to this, but by and large, that's the case. And when a VUS is identified, really what we're saying is we aren't sure if this is the genetic cause. And in that scenario, or when someone tests negative, we do recommend screening family members, first degree relatives, parents, children, siblings, screening their aortas and scanning them to make sure that there's no aortic disease.
Right. So a great answer, Elena, and I think you hit all the important points. Finding that pathogenic variant, as they put it, reports in a specific gene, really powerful information for the family, because you can go through and figure out the variant and is at risk and who isn't. And that can be such powerful information. And then it also allows us to really dictate the management very carefully that we've gotten to study, and we hope to get to them all. But then we can say when your aorta needs to be fixed. Do you have to be imaged for aneurysms in your brain or not? Do you have to worry about having early onset coronary artery disease or not? Because it is different from gene to gene. So it's incredibly powerful information. But without that, as Elena said, we just image everybody in the family. So anybody with an aneurysm and dissection, with or without a family history, needs to be imaged. So that's parents, siblings, and children. And then in families where we know it's being passed in families, that's oftentimes based on the family history, we have to reach out and image even more individuals. So if there that's had aortic disease, then we have to image their children too, even though they're not first degree relatives.
Do you have a recommendation for people with regard to the frequency relatives need to be imaged, or what time they should start thinking about getting screened if they have kids?
Yeah, that's a really tough question, and we don't have any hard data. I think that for adults, I think up to about the age of 40 or 50, that they probably need to be imaged maybe 3 to 5 years later. But if somebody's 80s or 70s and it's normal, then I wouldn't worry about re-imaging them at that point.
Yeah.
And in terms of children,
Yeah.
I'd like to get a baseline image. If everybody in the family if you have a family history and everybody has had onset of the disease in their 40s to 50s, we will get the baseline imaging and redo it maybe 5 years later after that. And we certainly, if everybody's had late onset or adult onset disease, I don't think we have to sedate a child for imaging. So we can wait to do imaging once they're old enough to sit still for the echocardiogram without sedation.
That's great. And a few comments have come in really for both you and Bella with respect to the program, and that is, how do you find resources to address questions? And in the case where a genetic cause is not identified, but an aneurysm is known and you're monitoring it, the decision that you as a patient make with your surgeon about when to repair and how large the aneurysm should be at the time of repair is a tricky one, and sometimes requires getting a second opinion. And it would be nice if Bella could comment on the resources she can provide in terms of connecting patients with local resources, either for genetic testing or surgery or cardiology.
Sure, that is a good question, and normally what I do is provide resources to help direct the patient depending on where they live. So we use a directory that was established by the Marfan Foundation. So that's primarily what I use to direct to local or aortic centers nearest to a person. So these centers typically have genetics component where they can get the genetic counseling that they need. They also can have cardiologists or surgeons that they can kind of all see at the same center, and everybody's, they are familiar with these cases. But if that's not the case, if travel is not an option, there's also a genetic counseling directory that I provide. It's something that you can Google. It's the National Society of Genetic Counseling or American Board of Genetic Counselors, and you can locate one by phone on there or one in your city. So any genetic counselor should be trained to, evaluate your risk and help coordinate that testing and interpret the results. I also do provide the American Heart Association guidelines, which provide the screening recommendations, and always encourage, the patient participants to share that with their physicians and their family members who are at risk. And then the other thing that I share is the John Ritter Foundation website, of course. So I share the Ritter rules, so that way they know what risk factors are that cause an increased risk for dissection that they could share with their physician. So I'll kind of just send an email of all of these resources where they can find support as well as medical care that they might need.
That's great, because Dr. Milewicz, well, I was going to say, I think you can probably speak to the piece on how these decisions are made and how you would incorporate family history and genetic testing into the surgical decisions.
So if you have a family history of aortic disease and you yourself are found to have an aneurysm, the best data we can get is if what is the aorta at the time of dissection in your family members, because that can inform how we manage your aorta. And we're actually pushing cardiovascular surgeons across the country information in the same place in the medical record, so we can find it, or you can find it, and very rapidly, and have the highest quality data from your family member. So pretty much all we have to go on is managing the aorta. If there is other family members, if you have some family members that have thoracic disease, but some that had intracranial aneurysms, then we would recommend imaging of the brain also for aneurysm. So we go back to that family history to dictate your management.
And can you maybe speak more globally to the association between aortic aneurysms and aneurysms in other arteries or bicuspid aortic valve? Because we know that they are connected. How do patients know if they're at increased risk for aneurysms elsewhere if a gene has not been identified?
If the gene has not been identified. So there is an increase for intracranial aneurysms in individuals with BAV. I think the new updated treatment guidelines will recommend at least one screening imaging of the brain in people with bicuspid aortic valves. But in terms of individuals that have aortic aneurysm and don't have known intracranial aneurysm, and there's no family history of intracranial aneurysm, the risk appears to be very low. And at this point, we're not recommending imaging of the brain.
Okay. And a few people have commented on if they have a genetic condition themselves and it is known, and they have a bicuspid aortic valve, for example, and aortic disease, or perhaps not, and family members are screened and are negative, do they need to continue to get imaged?
Aneurysms?
Oh, you cut out a little bit.
I just wanted a clarification of the question. But
if someone has a genetic condition and a bicuspid aortic valve or ascending aortic disease, and their children, for example, are screened and are negative, do they need to continue to be imaged if the children are not determined to have that genetic condition?
You mean based on a mutation, or?
That's right. That's right.
Yeah,
Yeah.
no,
They have a known genetic condition, but the children do not. Yeah.
Okay, then no, they don't have to be imaged.
Yeah,
Their risk
so-
goes back to that of the general population, where we don't image all children for thoracic aortic disease.
We can definitively say if someone has a known genetic cause and their children test negative, that they are not at increased risk. That's a real confirmation and definitive risk.
Yeah.
Okay, good. And back to the VUS thing. With genetic testing, we know that the information changes over time, both by way of new genes being identified, but also the classification or interpretation of the variants can change over time. Is there a general recommendation, and perhaps Ellen, you can comment on this because you work with a lot of individuals who have variants in genes. Is there a general recommendation for if a VUS is issued, how often you should go back and take a look at that? Or do you contact a genetic counselor? Will the lab reach out to you? How often does that change? And how do you handle that?
Yeah, for folks who come to us who have this variant of uncertain significance, which definitely can be a frustrating thing, I know, as the patient to not have be able to really sort yourself in one of these two buckets. We usually tell about every 3 to 5 years they should check in with their provider who ordered the genetic testing or a genetic counselor to see if there's been any new insight into this variant. We learn more all of the time, and so many more people are getting genetic testing these days that it's really expanding our knowledge very quickly. So definitely recheck in. They may not reach out to you. I've definitely heard from folks who checked in and received this information, but sometimes they may contact you as well. But it can't hurt to reach out every 3 to 5 years and say, is there any updates? Are there new genes that have been discovered that can contribute to aortic disease that you should be tested for additionally? This is especially true. I talk to folks sometimes who were maybe tested in the early 2000s or 2010, where their testing is 10 or 15 years old, and maybe they were only tested for a few genes that we knew about at the time, like Marfan syndrome or Lowe's-Dietz. And now we know about so many more that it may benefit you, depending on your specific health circumstances, to expand that testing and see if maybe you fall into one of these new genes that we've discovered since then.
That's great. And in the interim, while it's still classified as a VUS, then we recommend that you continue to follow and that your family members get imaged until that changed. And in some cases, working with your genetic counselor to get family members screened may actually lead to that variant of uncertain significance changing. So that can be really helpful to work with your local genetic counselor there. Okay, I think many of the questions have been identified, although one of the themes that continues to come up is the concept of penetrance, because I think it is pretty confusing. And how does that family history you showed, Dr. Milewicz, it kind of looks like things are skipping generations, but that's not really happening at the gene level. It just appears to be. And so if someone has an aneurysm and has a child who doesn't, and then you see it in the following generation, can you explain how that all fits and why that happens?
The decreased penetrance, we don't know why it happens, but
Well-
it does make it complicated in terms of determining the risk. And we've discussed a lot, like if you have a family where a woman where you know it's being inherited from one generation to next, and you have a woman that doesn't have any aortic disease, should you go ahead and image their children? And we just don't have the data to say whether you should do that or not. And at the same time, there's other genes where we know that the penetrance is exact same between men and women. And that was the case, that is the case for PRKG1. So that young girl I talked about, you would have thought maybe she was at a lesser risk than her two brothers of dying of dissection. But our data from MAC says no, women have the same risk for dissection as men with that gene. Why is that? And it's so different, with decreased penetrance in women. These are fantastic research questions that need to be answered. And and hopefully it's something that we can address through funding through the JRF in the future, our group or other groups. And it's one of the reasons to really contribute to funding, so we start understanding some of this. Because if we can understand why one gene makes it more likely that women don't have the disease, and another gene, both men and women have disease at the same level, it may tell us a lot about preventing disease. And because there's something going on and it's on the X chromosome or involves hormones, don't have any data right now.
Yeah. And it's not really that it skips generations, though. That's, I guess, the thing that we don't maybe understand why some people develop a dissection, some people don't, but they may inherit the gene change. Yeah, they may inherit the gene change. It just doesn't present with dissection as early or at all. And it could be that perhaps some people have inherited the predisposition, and they have one of these other risk factors, like you mentioned, like high blood pressure or pregnancy, and that's really what pushes it to a younger age.
Exactly.
In some people.
Exactly. And I want to mention that one pedigree where I was showing the decreased penetrance. That woman actually had a dissection and she was well into her 80s. So we still, if you've got that altered gene, we still have to follow you and watch you carefully because you're still at risk for a dissection. Fortunately, she did very well and recovered from, and then
so you can't give up on screening. What? You can't give up on it. You can't give up on
imaging. Give it up. No matter what age you are, if you've got that altered gene, you're still, that risk is still there. You got to stay on the medication, get the imaging, and try to follow the guidelines in terms of activities.
That's great. Well, I think we addressed most of the questions, and Meredith provided information for the John Ritter Foundation, and she can also, if it's not available, provide the email address to the John Ritter Research Program. They're separate but linked, and Bella is the person who receives the inquiries from the John Ritter Research Program. So there were a few questions about directing to local resources and testing, and if you send an email to the JRRP, we will be happy to get back to you.
Yeah, absolutely. Thank you for joining us today. Hopefully you got some information and now know the direction we're going. And thank you to everyone that's already participating in our research. So thank you.